Thank you, Mira. Welcome, everyone. I think we saw up there on the side, this is the 40th slide seminar, so glad to be beginning here. So let's jump into this case number one. We have a bit to cover in the next 15, 20 minutes or so. So the clinical history of this patient, I think you saw in the pre-meeting details. This is a 52-year-old male, originally presented in April of last year with urinary frequency, was given some antibiotics without relief, and because of the continued symptoms, they sent him for a CT of the abdomen and pelvis, which showed some lymph nodes in the rectal fossa, the left iliac chain, this sort of vague, mild urinary bladder thickening, and importantly, notably an enlarged and somewhat asymmetric prostate that was deemed to be, at least radiologically, inseparable from the bladder base. Within a week or two, he developed hematuria and underwent TURBT. And these are the next images I'm going to show you are from that TURBT. And again, note, this was at an outside institution where this was being worked up, not at Memorial initially. So on the left, we see what the tissue chips from the TURBT look like. You can see they are pretty dark, cellular at a 1x magnification. And on the top right, we can see the lesional tissue within the right-hand side of the diagram, adjacent or underlying and pretty normal appearing urothelium. If we get an arrow up here, a pretty normal appearing urothelium with some reactive umbrella cells. And here on the bottom image, see a medium-sized detrusor muscle bundle, PT2, muscularis propria invasion. More morphology, a lot of crush artifact. But in areas, and I'll tell you, looking over the slide, only a very few areas, some structure. Sheets of cells, some evidence of nuclear molding, maybe some trabeculation, rough trabeculation in areas, some cylinder-type architecture, and at a much higher power, very high NC ratios, and I've only pointed out most of what I think are mitotic figures, let alone apoptosis. And so at the outside institution, they performed immunohistochemical staining, not surprisingly given the morphology, neuroendocrine markers, TTF, and Apache CAM 5.2, and they diagnosed small cell carcinoma within this bladder TUR specimen, and they noted that there was extensive lamina propria invasion extending into muscularis propria. Importantly, they didn't identify any in situ urothelial carcinoma in this TUR specimen. Patient's clinical history continues. Within the month, he goes for additional imaging, and I'll just note that the PET scan specifically is that there seemed to be diffuse bony metastasis, pelvic metastasis and adenopathy already, and given the diagnosis of small cell, the patient is started on carboplatin and etoposide and Xgeva, which is a bone-reinforcing agent, given the potential for lots of metastasis seen on radiology. And an interval scan shows a somewhat decreased nodal and osseous disease, no new lesions, but notes an asymmetrical thickening of the posterior bladder wall. And about 4 months after diagnosis, the patient presented here to medical oncology for a second opinion. And we got one H&E slide where we were able to confirm the diagnosis of small cell carcinoma morphologically, again, with the immunopanel from the outside. There was a clinical discussion between our oncologist and the patient regarding continuing the regimen for more cycles. That was recommended. And there was a discussion of genomic profiling the tumor with our MSK-IMPACT, the next generation sequencing assay, over 400 genes, detecting rearrangement, mutations, copy number abnormalities, among other things, to identify potentially actionable alterations. And the patient consented to this. And then our oncologist had a discussion with the outside clinician over whether this was bladder or prostate origin. And said that this, the next generation sequencing test may be useful. You remember the original radiology was the irregular asymmetric prostate, inseparable from the bladder base. Later, we had asymmetric wall thickening in the bladder as well. And so this was still in doubt. And in fact, MSK-IMPACT assay was performed, and within what we call the clinically validated panel, P53 mutation was detected, and within the investigational panel, you'll see that there is RB1 deletion, and these two are very notable in small cells across organ systems. But you also notice there at the bottom, very importantly, that we detected a TMPRSS2 ERG fusion, which is pretty pathognomonic for prostate. Not surprisingly, because they're present in a lot of prostatic origin carcinomas, P10 deletion, and MYC amplification. So this looked like a prostatic origin picture, and so the final diagnosis is small cell carcinoma of prostatic origin. again involving the muscularis propria, in this bladder TUR specimen. What do we know about high-grade neuroendocrine carcinoma of the prostate or of prostatic origin? We're told by the older literature that this is 1 to 5% of all prostatic malignancy, and they show a similar morphologic spectrum as in other sites. And here you can see a lower-grade tumor divergently differentiating into a high-grade neuroendocrine small cell carcinoma. But importantly, most of the high-grade neuroendocrine carcinomas described of prostatic origin or in consequence with prostate cancer are seen in the post-therapy setting. Specifically, post the setting of having given androgen deprivation or some type of hormonal therapy. Unfortunately, these tumors are really bad, often unresectable, have a high frequency of visceral metastasis, which we'll get back to in a moment, limited survival, and the few cases in the literature, and I think there are about 6 or 7 that have been described as large cell neuroendocrine carcinoma, akin to the features described by Dr. Travis in the lung and elsewhere, have all been in the context, again, of treated disease. Importantly, the diagnosis of small cell neuroendocrine carcinoma is the only basis of giving chemotherapy as a first-line treatment in the setting of high-grade cancer of prostatic origin, as opposed to bladder cancer, okay? Where even for high-grade urothelial carcinoma in an institution such as ours, you'll get a chemotherapeutic regimen that will involve platinum, but the dose-intense type chemotherapy, the pulmonary dosing is in the prostate is only with this diagnosis. I note that the plus or minus androgen deprivation therapy, because about 50% of these cases are seen together with prostatic acin or adenocarcinoma. Well, after MSK-IMPACT was done, there were some leftover unstained sections. And so we investigated a little further at no charge to the patient. Okay? And not surprisingly, sort of going along with the findings in the molecular assay, you can see the strong expression of P53. You can see RB loss, and there's some endothelial cells or lymphocytes in the background there. You can see P10 loss predicted by the molecular assay, with the exception of the few endothelial cells seen there. But maybe more surprisingly, in a patient we now know has a Temperis 2 ERG fusion, ERG, immunohistochemistry, which is a beautiful nuclear stain usually, was negative other than in these capillaries and endothelial cells. Maybe not as surprising in terms of the morphology of this tumor is that PSA and NKX 3.1, 2 prostatic markers, were negative. But this ERG negativity was a little perplexing given the fusion that was detected. So what do we know about Temperis 2 ERG rearrangement, specifically in prostatic small cell carcinomas? And I've given a series of references here on the right that are also in the references that are either have been made or will be made available to you regarding this meeting. Well, early studies in very small cohorts showed rates of this rearrangement in prostatic small cell carcinomas of 70 to 85%. And those authors use this as an argument that this was a sign of aggressive disease, that the rearrangement itself was a sign of aggressive disease. However, as larger cohorts became available, the percentage went down to about 45%, which is actually not different than that seen in primary disease. And so it was seen now not as a proof text, as it were, for rearrangement being associated with aggressive disease. Importantly, the studies quoted by Lotan and Williamson showed that in cases that had concurrent usual acin or prostate cancer, nearly all showed concordant rearrangement status as the small cell carcinoma, supporting the notion of divergent differentiation. Now, usually, when this rearrangement occurs, ERG is brought under the regulation of the androgen receptor, or androgen regulation. And therefore, ERG immunohistochemistry is usually a very good surrogate for this rearrangement being present. However, in cases where there's been androgen deprivation therapy, and the patient has progressed past it to the androgen-independent state, or what's called castrate-resistant state, there's no more AR, right? And if you don't have AR in an AR-regulated system, you're not necessarily going to see protein expression. And so, ERG, by immunohistochemistry, PSA, NKX 3.1, all androgen regulated, can potentially not be present as they weren't in this case. And so in those cases, in the androgen independent state or castrate resistant state, ERG-IHC may not correlate as well with rearrangement status as it does in usual acin or prostate cancer. And this was brought home by the last study on the list by Udiger et al. From University of Michigan in warm autopsy series, which showed this quite nicely. Very important in terms of differential diagnosis, all of the bladder small cells and lung small cells that have been tested throughout these series have been negative for the rearrangement. So it's a very powerful marker in this setting by FISH, or in this case, sort of through the back door by a next generation sequencing assay for prostatic origin in these tumors. So aside from this important diagnostic point that just doing an immunohistochemical stain in this setting and finding it negative might not rule out the rearrangement, why is this case unusual? Well, these tumors are rare in general, but beyond that, there was no prior history of prostate cancer and no evidence morphologically of prostate cancer. This patient doesn't have a prior history of androgen deprivation therapy. And I focused on the radiology a bit because the initial metastatic pattern was to lymph nodes and bone, and that's typical of usual high-grade prostate cancer, as opposed to small cell neuroendocrine cancer, which has a higher incidence of visceral metastasis. And probably most strikingly, this notion of the IHC being negative for ERG, PSA, and NKX 3.1 indicates a tumor that's already, let's say, transdifferentiated to an androgen-independent phenotype in the absence of any androgen deprivation therapy, which is not seen commonly. And this case has been in discussion in the past 24 hours as I was preparing this amongst the colleagues, because this seems to be a highly unusual point. And so the question of, is there unsampled tumor in this prostate? We've never had prostate biopsies on him. The lymph nodes haven't been sampled. He hasn't had a bone biopsy. Could there be other high-grade acin or prostate cancer hiding out in this patient that was there long enough to have gone to the neuroendocrine or androgen-independent state, leading to the immunohistochemical findings? And this whole, diagnosis and sequence of findings has come into greater focus and interest recently because of a clinical syndrome that medical oncology colleagues are seeing. And this is castrate-resistant prostate cancer with aggressive clinical presentation. That's my benign way of putting it. They've called it, quote, small cell or anaplastic. Not a morphologic definition. There's quite a bit of morphologic plasticity as to what these are. And in fact, the majority of them are probably just high-grade prostatic acin or carcinomas, even in the metastatic setting. But they've called them small cells. So, and this is a syndrome with visceral metastasis, lytic rather than the traditional blastic bony metastases, and a whole bunch of other things. You can measure high serum chromogranin in some of these patients who don't have the morphology of small cell, very interestingly. And so there's been an increased focus on trying to refine what is neuroendocrine tumors of the prostate, or what is neuroendocrine differentiation. That's led to two sort of attempts at classification. The first is from a paper from a conference held in the local vicinity and involving a number of people from our institution under the guise of the Prostate Cancer Foundation. The other one is the WHO 2016 GU tumor classification. These are essentially similar, except that the mixed category on the left is subsumed in both the small cell and the large cell on the right. But importantly, neither of these, and it's acknowledged in the paper, take into account a subset of these cases. And we'll get a little more into that as we go. To take 2-3 steps back, neuroendocrine cells are known to occur in the normal prostate. You can note their dendritic quality by chromogranin stain. They're not seen on H&E typically. They secrete a variety of peptide hormones and affect target cells by all sorts of mechanisms. This is a working classification that our group has been using in order to sort of better get our hands around tumors that fall in and amongst the things quoted in the traditional or the more recently proposed classifications. And I want to note specifically to you this fourth category of prostatic adenocarcinoma with diffuse neuroendocrine differentiation. We're going to see a prominent example of it in a moment. Something that doesn't look like high-grade neuroendocrine carcinoma of any type, small cell, large cell, or the like, but yet has both of these differentiations, and there are analogs in other organ systems. We know that there can be neuroendocrine cells both in primary disease, 3+3, 3+4, as well as in advanced prostate cancers. And the number of these cells, their significance is debated and not really well known. However, more recent evidence suggests that neuroendocrine cells, at least in the advanced metastatic settings, can lack androgen receptor and may be an important escape or resistance mechanism to hormonal or anti-androgen androgen deprivation therapy in the advanced setting. And we know that they can, because it's part of their innate function, have paracrine effects that would go towards creating an advanced or metastatic picture. I think within the spectrum, I think we're all used to the finding on the top left, or we've read about it, the finding of random Paneth-like cells which don't have lysozyme and stain for neuroendocrine markers, so we'll call them Paneth-like and not Paneth. We're used to that. We even may be aware of the top right, that these occasionally can occur as single cells, cords, or even nests, creating a grading problem. And it's been suggested that we not grade these because they happen to be associated with low-grade cancers in many circumstances. What we may not know is that these are prominently seen in the case of prior therapy. And we see cells here with typical anti-androgen effects, these bubbly cells like post-hormonal therapy, then intermix these like very granular red cytoplasm, this Paneth cell-like change. There's a whole literature on prostatic carcinoids. Outside of the realm of multiple endocrine neoplasia in children, nearly every one of those cases, if you read the case reports, the small series, and actually look at cases, is associated with prostate cancer or with evidence of prostatic differentiation. As in this case, radical prostatectomy, post-androgen deprivation therapy, we see nests and ribbons, trabeculae of tumors, which at a high power have salt and pepper nuclei, but show both staining, which is actually quite diffuse in our hands, for PSA, synaptophysin, and chromogranin. So prostate cancer with carcinoid-like morphology. This is a more unusual scenario which we are only first recognizing within this spectrum. This is from the liver of a patient who'd been treated with androgen deprivation therapy, hormonal therapy, and we saw sheets of cells. And at high power, you'll note that they have plenty of cytoplasm. This is not small cell carcinoma, doesn't really have features of large cell carcinoma. You can see some prominent nucleoli, as you would, and probably in the center, and I've highlighted it there in the center, you can see that same bubbliness from hormonal therapy that we see, albeit not with the pycnotic nuclei. And interestingly, it stains for prostatic markers, but it also stains diffusely for neuroendocrine markers. And so this emerging category of prostate cancer with diffuse neuroendocrine differentiation and diffuse neuroendocrine marker positivity, which may have analogs in other systems, but not well defined in this setting, needs to be further fleshed out. We've seen a case today, that's our case, but here is a biopsy showing small cell high-grade neuroendocrine carcinoma, which on the right, I think even at a low power, you can appreciate a high apoptotic rate. On occasion, you can see rosette-like patterns, more trabeculation, sort of spanning the morphology of high-grade neuroendocrine carcinoma. Very commonly, about 50% of cases on presentation are seen in this mixed setting, where you have otherwise high-grade prostate cancer on the right, neuroendocrine carcinoma on the left, very nicely highlighted by differential staining for prostatic markers, and in this case, TTF1. From a differential diagnostic perspective, of course, metastasis from the lung or other sites. But in this particular site, and in the case that we've shown, this TUR of the bladder, is it prostate or bladder origin? And of course, you want to look for, from left to right, urothelial carcinoma in situ, high-grade papillary urothelial carcinoma, an adjacent invasive urothelial carcinoma, NOS, or an adenocarcinoma or other divergent differentiation, as you would see in the bladder. But we didn't have any of that in our case. Recently, Anu Gopalan and I and our team, and this is a work in progress, and I'm going to finish with this, have started to evaluate in a consecutive fashion morphology of neuroendocrine differentiation in the setting of prostate cancer. We've looked at 76 cases so far from the past 5 years. Note that 30 are primary in the prostate, 46 metastasis, and very significantly, 80% of them, when we looked into their histories, are post-therapy, unlike our patient. When we look at the categorization of them, this becomes even more stark in that the pure small cell high-grade neuroendocrine carcinomas and these cases that I've just shown you, that prostate cancers with diffuse neuroendocrine differentiation showing both prostatic and neuroendocrine markers, occur almost exclusively or exclusively in the metastatic state. And so our case, which was occurring in a primary site, prostate to bladder or involving that region, seems to be the unusual outlier. And so some take-home messages from this case. if you see a small cell or high-grade neuroendocrine carcinoma, something that you can identify as such in the region of the prostate and bladder, or in the setting of a prior prostate cancer history in a metastatic site. So first, if it's in a primary site, look for evidence of prostatic and urothelial differentiation, of course. But note, especially in the metastatic setting, or as in our case, you may need FISH or a molecular test to help determine the origin, because these tumors may be negative for ERG, for PSA, for NKX 3.1, any other prostatic markers you can throw at it, while still harboring the TMPRSS2 ERG rearrangement, which is a very powerful marker. I also caution to be aware of the emerging spectrum of neuroendocrine findings seen in the setting of prostate cancer, as these are getting a lot of attention, or an upcoming attention, based on papers I'm reviewing in the literature, because of the giving of much higher powered androgen deprivation therapy in the form of abiraterone and enzalutamide to patients in the metastatic setting. Thank you very much.